We have a fantastic panel to continue the conversation, including Lori Montgomery, the Deputy National Editor of the Washington Post. She'll serve as moderator. We've got Tom McInerney, the President and CEO of Genworth, Steve Messenger, the President of ECG Management Consultants, Robert Popovian, the Senior Director of the U.S. Government Relations at Pfizer, and of course, the President of the Joe Minerick Fan Club, Alice Rivlin, who will be here, and she represents the Brookings institution. Thank you.
Hi, everybody. The first thing I was supposed to was introduce everyone, but I think that's already happened. So why don't we just dive into the conversation? And I would love to start where Congressman Pitts just left off. I mean, clearly the landscape has changed dramatically given last week's election. And I'd love to hear from each of you about how things you were expecting to happen, perhaps under the Affordable Care Act, are now sort of being called into question, and how it changes how we think about what's likely to happen in terms of Medicare and care for seniors. Do you want to just start?
Sure. So I'm pleased to be here. My name is Steve Messenger, and I perhaps have a slightly different perspective, and that's really colored by my experience. I am a management consultant. I work with hospitals and medical groups across the United States on strategic and financial operational issues. And I think that one of the things that when you hear from our customer base in terms of their reaction, obviously there is a pretty big element of surprise. But I think the other thing is that to one degree, this is very reminiscent of the first Clinton presidency health reform. We often said then that we could declare victory even though there was nothing that was passed from a legislative perspective. When you talk to hospital CEOs, health system CEOs, medical group presidents, physicians across the United States, their heads are down on this path to value. And the notion that we have this incredible waste of resources that we're spending every day, about 30% of the cost of healthcare is wasted. So I think that from one perspective, their heads are down and they're still pushing on the elements that employers are looking for, that the patient base, the consumer is looking for. I think what they're looking at right now is how quickly things are going to evolve. And just real briefly, if you think about the current world that the health system is living in, and the congressman pointed out this, it's generally a fee-for-service world. It's piecework. The more pieces I produce, the better I do. It's just that simple, that straightforward economics. Under the Affordable Care Act and under a lot of other legislative initiatives, we're really migrating to a system where I'm trying to not only reduce my units of my cost per unit of service, but I'm actually trying to reduce my units of service. And so if I've geared my entire industry up to being piecework, and all of a sudden piecework is bad, I'm living as a businessman, a physician, or a president of a health system. I'm living in both of those economies. And it's incredibly difficult to live with both of those incentives, which are absolutely contrary to each other. So I think that one of the things that organizations are doing is trying to decide, what do I push on, what do I drag my heels on? And I think this gives us a great deal of pause as it relates to how fast do I want to push on this whole idea of payment for value, as opposed to dragging my heels in this fee-for-service world that we already know.
Mr. Popovian?
Well, I look at ACA as having two components. I think the coverage and affordability part is one component, and then what was mentioned right now, and Congressman Pitts mentioned, is the payment side of it, which is clearly very important, that we have to go to a payment model that we are not paying for volume rather than for value. In addition, we have to change the system where we are able to pay for health care rather than sick care. Right now, the incentives is basically to create more volume, to charge more, to make more revenue. I think eventually what ACA will do, whatever form it shapes into, what MACRA is going to do, is going to mimic what we have already seen in the private sector, which is a move towards paying for value rather than volume, where you see in states like where I'm from, in California, almost 100% of some groups of physicians are under risk contracting for healthcare services. And the risk contracting doesn't just go about providing physician services or hospital care, but also includes pharmaceuticals. And we've noticed, I mean, Congressman Pitts mentioned about Medicare Advantage. That's the ultimate capitation model, right? You give a single amount of dollars to the healthcare provider, whoever that may be, and that person takes on the risk of providing all the services for that patient. And that's what we're going to go towards, I think, in the future with regards to paying for, whether it is for physician services, hospital services, or pharmaceuticals even.
Mr. McInerney.
So just to introduce myself, I'm Tom McInerney, the CEO of Genworth. We're the leader in long-term care insurance, and I'll talk about that maybe just for a second later. But I, you know, having worked for almost 40 years, I would say that I have been struck every decade by the role that demographics is going to play in the United States and around the world. I think most people know the number that there are 10,000 baby boomers turning 65 every day, and that will be the same for the next 20 years or so. The oldest baby boomer is 70, so in 10 years I think we'll see, it won't be 10,000 per day, but I think it will be 7,000 or 8,000 per day turning 80. And 80 is you can get sick anytime, but 80 is the year where you really start to have, you know, I think most people know for medical care, as opposed to long-term care, 90% of what you'll pay in a lifetime are paid in the last 3 years. So that won't be too far away for baby boomers. And then for long-term care insurance, and these are insurance or just the services for activities of daily living, cooking, being able to eat, go to the bathroom, get dressed, being mobile. The number of Americans that turn 85 will triple over the next 20 years or so. And 43% of the people who turn 85 will end up with severe dementia or Alzheimer's. So while there are what both of these gentlemen said and what the congressman said, I think are critically important, but big picture, whatever we try to do to rein in costs will be overwhelmed by the demographics. And I think that entitlements overall, you know, different people come up with different numbers, but I think if you look at all the entitlement together, including the Veterans Administration, Medicaid, Medicare, and Social Security, it's over $100 trillion of unfunded liabilities. We know there's a $20 trillion debt. And so I think we have no matter who is president, we have an incredibly difficult next 20 or 30 years, because I can't imagine in the United States we will not care for these 80-year-olds or 85-year-olds or 90-year-olds, but the cost of doing that and how to pay for it and who pays for it, I think are tremendously difficult issues.
Hello, Alice. Good to see you. I know these are issues that you care deeply about. How do you think the world has changed? And
I think it's changed quite dramatically since the election, but in a way that was just a wake-up call. It was reminding us that it's easy to have slogans in this business. It's very hard to implement the things that people say in their slogans they want to do. And Congressman Pitts gave a very good illustration when he talked about using reconciliation, which they could do, to close down the subsidies for health care under the Affordable Care Act and the taxes that went along with paying for it and other aspects of it that are financial, but keep the insurance reforms that gave parents the right to keep their kids on their insurance until they were 26, and which sounds nice, but it's kind of expensive for insurance companies, and even much more important, prohibited medical underwriting or taking into account the health of the person when you are pricing and selling insurance. And not allowing or charging very high prices to people who had pre-existing conditions. Now, those were very unpopular reforms, but keeping those and doing away with the things that made the individual market a viable or an almost viable proposition for insurance companies can't be accomplished by saying we'll do away with the subsidies, but we'll keep those things we like. That would lead to an almost immediate death spiral in the individual insurance market. And going back to where we were before the Affordable Care Act, where it was very difficult for quite a range of people to buy insurance. So I think we can't do that. And I think the President-elect Trump has realized that we can't do that. Most of the people in this room, and me included, are enthusiasts of the idea that you should set up both the working age programs and Medicare, if you can, in the form of competition among full service plans so that people can choose, they have a lot of choices among plans. Now, President-elect Trump, to his credit, I think, did not wade into Medicare at all. He didn't talk about it. He just said, we're gonna let it alone. That was a wise political decision. Because anytime you scare people, and there are a lot of us on Medicare, by saying we're going to reform it, you have only trouble in the political realm. Speaker Ryan, on the other hand, has come forward and said, not so fast, we're also going to take on Medicare. And that will be very controversial. But I think we've learned a lot about insurance markets from the experience of the Affordable Care Act. Now, some of you guys already knew that because you worked there. But some of that can be applied as we move in Medicare to more choice among private plans. And as the CED has said in its recent report, we've got a third of the population already in private plans in Medicare. Start there and see if you can make the competition better. But all of those things are going to be hard to work out, and they aren't slogans.
Well, let's stick with Medicare for a minute. I mean, it seems like so many questions have now been reopened on so many different levels, ACA, Medicare, what have you. What are the opportunities? Are there new opportunities and new ways of looking at Medicare reform that perhaps had been rejected in the past when we were looking at divided government, and we'll just go down the path again? Where do you see the opportunities in Medicare reform right now?
Well, I actually agree with Alice's point, and I think that, and the Congressman's point around Medicare Advantage and the opportunity to grow Medicare Advantage. I think that as we, if we're really trying to fix the, and it's multidimensional, we haven't gotten into the whole implications, impact on behavioral health and the inadequacy in terms of the coverage for behavioral health. If you look at where most of our spend is, it's on people with 4 or 5 chronic conditions. And guess what? If you have 4 chronic conditions, you generally are depressed. So you have a behavioral health contraindication. We aren't really touching that. I think that's a ripe area. I think that one of the things that is just amazing to me is the gap between the market and the policy leaders and the policy thought leaders. You know, if you think about the implication to the physician who is taking care of a Medicare patient, you have effectively 2 choices. One is that you can accept a very, very meager payment relative to what you're going to get from seeing somebody who is insured by Blue Cross or United or so forth. Or you can decide that you're going to join with a health system and become employed by a health system. There's a third leg of this, which is we see numbers of physicians and even hospitals in certain cases now opting out of some of the government payer programs. So I think that one of the things we have to be careful of as we look at reforming the Affordable Care Act and looking at reforming Medicare is the fact that we are redefining what an underserved population looks like. So under the macro law, which is the Dr. Fix law, so the deal is that CMS has said, doctors were going to give you a 25 basis points raise every year. So think about if your employer said to you, I'm going to give you 25 basis points of a raise every year, what you're going to be doing. So we're having this broad swath of physicians effectively limiting the number of Medicare folks that they're going to be taking care of. And I think you're having population centers in places like Tampa, Miami, other places where you're going to be tough. It's going to be tough to find a physician if you're a Medicare eligible person. So I think that we can't divorce the provider side implications on this because we are going to create this huge underserved. So the access issue, we're not going to be able to fix at all unless we really take that to heart.
So I'll repeat what I said earlier, that first of all, most important thing about Medicare is 10,000 people become eligible for Medicare every single day, and that will occur every single day for the next 20 years. And so the fact that we have a substantial problem in Medicare goes without saying. I do think, and I think Alice and others have said, I do think you need choice. I don't think one size fits all makes sense. I mean, some people will be more, some people less. I also think the more you can create competition, however you do that, obviously having more private competition, is there a role for a single payer as another competitor? You know, I don't know. I think it'll be very controversial, but I think that it's critically important to weigh into all of these significant problems. I'm trying not to say huge. You know, there's a lot of talk about bending the curve, and I get all of that, and I think at the margin you can do that, but ultimately there are a lot of people to be covered, and I think we have to just rethink how we do that in a way that, one, we cover the people, but two, we make it at least somewhat affordable for the poor millennials. I have 3 of them. They're going to have to pay for it all.
Do you see an opportunity? I know you're particularly concerned about long-term care insurance. Do you see an opportunity to address this now that all these questions are apparently going to be thrown?
Long-term care? You know, I think the challenge with long-term care, and Alex was in the Bipartisan Policy Center, BPC's task force on this. I think she came up with some great programs. Challenge we have in long-term care insurance, Medicare doesn't cover it. Medicaid is the payer of last resort. Only 8% of Americans have bought private insurance, so 92% are uncovered. We know the average baby boomer, 55, 65-year-old, has saved $100,000 or less. So I think we have to do all we can to encourage more Americans who have the ability to pay the, let's call it $1,500 to $2,000 premium per year. So get more than 8%. I think if we can double that number or triple it, we help take a lot of pressure off of Medicaid. One of the things that BBC recommended that I totally support is to consider worksite distribution, worksite sales, to encourage employers over a certain size to offer plans, perhaps have an opt-in like we changed for 401ks in 2006. And also be able to either put a long-term care policy within a 401k retirement program, because it's a big part of retirement security, is planning for long-term care, or perhaps just having a side program where pre-tax dollars can be used. So at least there's additional incentive for more people to be covered.
Mr. Popovian, if I'm not
So I look at it as an opportunity here. Right, so we didn't get a lot of the stuff that we wanted through ACA. One of the things that I think I'm fond of, which is look at micro level issues that we can tackle immediately that can make a difference. So somebody mentioned here administrative burden, right? We spend more on administrative costs in the United States right now than we do on pharmaceuticals overall. What is the thing to do? You cannot go to zero, right? So you need some administrative balance here. But what we can do is make things easier. So this is an opportunity to be able to open up the books and do interoperability, be able to do it electronically, a lot of the administrative burden that is being handled through paper right now. The other thing that I think it's important to note with this opening up and the discussion starting again is really looking at, if we're going to go to this new payment model, which everybody is moving towards, who's going to take on the responsibility of developing sort of quality measures to make sure, and this is my favorite word, I'm an economist, is this moral hazard problem that we have with physicians, which is basically they can either do more and get paid more, or do less and get paid more still in the new payment model. So who's going to develop those? Who's going to validate those? Or where are the patients going to be involved in it? So those are the micro level things that we're going to have to address to be able to make sure that now that we have this opportunity to address these things more holistically, how do we go about doing them?
To stick with coverage for a minute, I see two big opportunities at the moment. One is to fix the Affordable Care Act so that it actually works better. It's working quite well in a lot of markets, especially densely populated areas where there are a lot of people and a lot of providers, and it's not so hard to have competition. We need to fix some of the things that didn't work as well as they could. The risk corridors need to be widened, and other things that were unrealistically regulatory that didn't work very well, and probably call it something else. I don't care if we call it Trump Care or Donald Care or whatever. But we need something like the Affordable Care Act, and we need it to work. But the other is long-term care. We don't need a big new entitlement, but some of the things that were in the bipartisan policy report, in addition to the ones mentioned, are you could make it more feasible for insurance companies to sell long-term care insurance if you picked up the high-risk people. If you call it a high-risk pool or whatever you want to call it. But in long-term care, as in so many other parts of healthcare, much of the cost is in the people who need long-term care for an extraordinarily long time. There aren't very many of them, but they're awfully expensive. And if you could offload those onto a public pool in some way, it would make it more possible to sell the insurance, and then there are ways to make it more attractive for people to buy it.
I want to open it up to questions here in just a minute, but I have one last question that I can't help asking. Alice and I have been paying attention to tax reform, entitlement reform, the so-called grand bargain that kept trying to happen and never happened. And now here we are, once again, we're talking about tax reform, we're looking at entitlement reform. What cautionary advice would you have for the new administration about the risks of trying to tackle all this stuff?
Oh, there are plenty of risks, but if we don't do it, we're dead. So I think I would not try a grand bargain. We tried that, we came close, it's too hard. But I would, I guess my thing that I think is most important about healthcare, Social Security, and taxes is whatever you do, you've got to have bipartisan buy-in. And the tragedy with the Affordable Care Act, which was actually a very market-oriented, Republican-appealing kind of thing, the tragedy was that it was passed by a Democratic House, Democratic Congress, and the Republicans then thought they had to trash it. And even if much of it they would have liked. If they only had found a way to make it a bipartisan bill, I don't think we'd be where we are at the moment.
You know, Lori, in I think 1989 or 1990, the first President Bush had a entitlement reform group. I forget what we called it. And there were 25 people from both sides of the Congress, senators and congresspeople, and then people from the private sector, from very liberal to very conservative. And we came out with a program which had all negatives in it. You need to raise the retirement age, although I think we excluded blue-collar workers who had physical labor. We said you can't make them necessarily work to 70. Said you have to raise taxes. Probably the way we did that is to take the cap off of Social Security. Senator Kennedy was on the group, and he didn't want to do that because he felt that made it a welfare program, and that would create problems down the road. And then we also said you probably have to means test, which means 30 or 40% of the people who paid in all their life, deserve it, but we just can't afford it. And then ultimately, as we got closer to the baby boomers retiring, you're going to have to look for other sources of revenues. President Clinton kept some of us on, and he switched it to, it's called the Saver Summit, and it focused more on Social Security because I guess others were focused on the health part of it. But the recommendations were almost identical. And then Simpson-Bowles, it was interesting when I read that, whenever that was, 2008 or so, those recommendations were absolutely dead on to what we recommended in 88, 89. But here's the problem. There are 78 million baby boomers. In 1989, that was 27 years ago. And so they're 27 years and they're right in their peak retirement years. So they're going to go from paying taxes for their parents to now asking their kids and grandchildren, and there's, we all know there's like 2.3 workers or so in another 20 years. So I think that the solutions are clear, I think, to people on both sides of the aisle. I still talk to people, I was up there today, and both sides of the aisle say, well, yeah, those are all good solutions, but Tom, if I recommend any one of those, I'm out. And I think that's the challenge, is the political courage it will take. I totally agree that you can't do this other than on a bipartisan basis because, in the end, there are decisions where we either have to reduce in some way what we've over-guaranteed or do what Europe does, keep the guarantees, but raise tax rates. And I mean, really raise. I lived in the Netherlands for 4 years. Their marginal tax rate goes up to 52% at 40,000 euros, which is where most of the Dutch people, so that covered all of them. So they have a more generous system. But I will also tell you, they're also, this is a little bit scary, they're also the leading country in terms of euthanasia because what they're finding is when people on these national programs, even at a 52, that's just income taxes. On top of that, you have property taxes, the rest. But over 80, as I said, that's where all the costs are. So they are in some way dealing with that problem.
You're not suggesting this is a policy choice.
But I do think in the Netherlands, very seriously, that is something that the government has to deal with because of the cost when so many people are in the society are 65 or older.
I do think that one of the things that I think it would be a fallacy to walk out of here with the universal thought that everything in the Affordable Care Act was a good idea. I think that if you look at the history of legislation, especially as it relates to Medicare, there is a lot of what we've done that effectively says you can have it all. If you look at how other countries are combating this, for example, the ability to do medical underwriting and denying coverage for pre-existing conditions, it's a great idea. But you have to balance that with some ability to have a lock on an enrollee so that you're not taking such disproportionate risk when somebody who says, well, gee, I need a knee replacement this year, so I'm going to sign up on the exchange, and then every other year I'm not going to.
So you're saying don't throw out the mandate?
I don't know if I'm saying don't throw out the mandate. I guess what you're thinking about, we give seniors everything because of the powerful voting bloc. You just go north of the border and you have seniors that have a difficult time getting the hip and the knee replacement. I do think that we have this culture and this ideology where we want to give so much. And what effectively we're doing is this is a great risk transference mechanism from the individual getting care to everybody else. And I think we have to become honest about that because if you're being put in a risk pool with people that opt in and out based on I need a surgery or I'm sick, it creates this fundamental unbalance in terms of the economic risks that people are taking. And I think that we have got to recognize that if we are going to do things like, say, no to limitations on pre-existing conditions, we have to have some ability for insurers and providers to have some guarantee of lock of that patient population so that people aren't just opting in when they're sick and opting out when they're healthy so that we can have some balanced sense of risk and responsibility.
Are there any questions? Yes.
Joan Michelson, Green Connections Media. Thank you very much. A lot of people take better care of themselves, and I'm curious about the data that you quoted, Tom in particular, and how that might take effect into the planning that we have. Because there needs to be more, and there has been more personal responsibility for personal self-care. I wonder if your data includes factoring that in, particularly with the low end of the baby boomers, for example, and people in the next generations, and how do we incentivize the follow-on to that, so data, but also how do we incentivize positive health habits and disincentivize negative health habits, because we're all paying for people who abuse their bodies and they're not, in effect. So how do we, you're all talking about fairness to doctors and fairness to insurance companies, but we also want fairness to people who take care of themselves and have some incentive for personal responsibility.
That's an excellent question, and I agree 100% with the basis of your question. You know, at Genworth, I think over the last 40 years, we've paid 200,000 long-term care insurance claims, over $10 billion, and there's no question that wellness can be enormously beneficial. Every year we have a symposium in Washington where we invite various parties, and a couple years ago we had one on wellness. And if just deferring diseases 3 to 5 years because you've lived a healthier life, nutrition, exercise, simple things. You know, you don't have to run marathons to just eat well, exercise, probably not smoke, and not be too overweight. It is substantial how, one, you may not forever defer, say, something like Alzheimer's, but you push it back, and if you can either reduce it or delay it, it has enormous financial benefits for all of these programs. So I think it's very important to do. It's probably controversial because you're dealing with, the freedom of people to live their lives. But there's no question if you could incent better wellness behavior, it would have a huge benefit to these programs.
You know, there is something really interesting about that question. So number of open heart surgery procedures over the last several years have gone down about 26 to 30% because people are healthier. And when you think about the societal costs for that, it's sort of a paradox because what we're doing is we're saving people with heart conditions, which usually you would just be done, drop dead, and you're out of commission. We're saving those people so that they are now getting older and getting Alzheimer's and getting cancer, which are incredibly costly diseases relative to dying from a heart attack. So there is a societal implication
So we're
around...
back to euthanasia?
Around wellness and all of those that actually might increase costs.
What about corporate wellness?
I'm not sure if we're living healthier. That's why we're having fewer cabbages in the United States. I think it's because of the advent of statins probably and biopharmaceuticals, and that's been proven pretty well. But one of the questions that I want to address your question is, for somebody who has actually seen patients and treated patients, and you get so frustrated when the patient walks into your clinic, you adjust their medicines, you give them everything they need, and then they come back the next month with the same exact problem. And this happens over and over and over again. So it's not only about making things available, about wellness and things like that. Patients need to take personal responsibility, and it was very enlightening to see that there was a paper written by American College of Cardiology, American Pharmacy Association, American Heart Association, and the question they asked, what is the responsibility of the patient in this new paradigm of payment reform? Because I can, as a physician or a pharmacist or a nurse, do everything right. Patient goes home, does everything wrong, but they have no responsibility, and then I get docked for my services. So that's an important question that we need to answer. And it starts with basically taking better care of ourselves, but it also involves taking our medicines, listening to our physician, listening to our pharmacists, and so on and so forth.
I just want to subscribe to the questioner's point, but also to make the point it isn't just incentives. It's creating a culture of health, as the Robert Wood Johnson Foundation likes to say. And that's serious. It's got to start in school. It's got to start in preschool. It's got to start in neighborhoods. You can't be exercising in a neighborhood where if you walk out your front door, you get shot, or where there's no park or there's no place to go. So we've got to think about this as a societal question. How do we make it more possible for people to lead healthy lives and incent them to do so?
Are there other questions?
Question.
Okay.
About 45 White House fellows recently got together to talk about ways to address health care. And a lot of people said you have to change the whole medical system, blah, 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 which we may never get through, okay? Is there a way we can bypass the existing system? I'm on this health bit. For example, a lot of the problems relate to not having education or sufficient communications. Many families don't realize that there is a trade-off between the cost of the last 3 years of care and whether there's any value to it whatsoever, okay? A Stanford professor recently did a study that showed that the gigantic advance we've made in energy is not from solar panels and windmills, it's the fact that Americans have moved to better energy efficiency cars, put in solar panels on the roof, and LED, and all these little raindrops resulted in a gulf of improvement. So I'm thinking of including health teachings on Sesame Street. 60% of Americans already use integrative health, including acupuncture and massage and herbal things, and nobody sort of dragooned them or gave them a prescription for that. So I'm just thinking that there may be a way through education and things like games. Most people in the world have a cell phone. They may not have a TV, they may not have a computer, but there may be ways we can try to uplift everybody with some education. Now, if you're gonna wanna smoke, there's nothing I can do about it. But if you don't know that eating all that salty stuff gives you high blood pressure and what the symptoms are, maybe we can do something about that.
That's an excellent point. Anyone want to take that?
I agree with the points. I think the more you can do to educate society to live healthier and to not do the things that can lead to higher incident of these diseases, I think is definitely a big positive for sure.
Yes.
I'm Alice Jacobson. I'm with the American Payroll Association, and I have, I guess, sort of a two-part question. You've talked a lot about increasing competition to keep the costs down, but how do you do that, and is there something that can be done via legislation for that? And the second piece of that is, as payroll professionals, we have a huge burden on the administrative side of managing all of this and doing some of that reporting. Is there some way that sort of that side of it could be reduced or managed better?
So legislatively, I'll address that in two ways. One, I'm a registered pharmacist in California. I moved to Virginia, I didn't lose my skills. There's no point of having state licensure anymore. I think it's ridiculous. People who travel across state lines don't lose their knowledge of medicine or pharmacy or nursing or optometry and so on and so forth. These are all boondoggles that we've created on the state level to basically make money for the state. Let's get rid of that. We need a national licensure. Patients are not different in California, believe me, than they're in Virginia. And neither is the pharmacy, neither is Lipitor, neither is any of the other drugs. The number two thing is we need to get over this scope of practice issue. 10 years ago, if you listened to AMA, everybody was gonna die because pharmacists started vaccinating people. Okay, there were going to be Armageddon outside in the streets. People were going to fall off this needs to end. And that's one of the ways actually we can address the shortage of providers, is that we have these artificial barriers, whether it's the state licensure issues or scope of practice issues, that basically are keeping away patients from the most accessible types of services, whether it's pharmacist services or nurse services or optometrist services. We need to rethink how we're doing these licensures. That's legislatively, both of those things can be fixed.
I think that there's just one quick anecdote is that when you think about transaction costs in healthcare, they're ridiculously high. You know, in France, for example, it's obviously a nationalized health insurance market. Transaction costs are around 3-4%. In the United States, best-in-class health plans generally look at about a 15% administrative cost. The rest goes to healthcare. We did a study for a local hospital where we looked at transaction costs, and if we had gone to the Medicare billing rule just as a standard and used that as a common standard for the billing and claims adjudication, it was it was 18%. It was $18 million on a $100 million net revenue base. So when you think about in financial services what they've done with technology to lower transaction costs and swiping of the cards, boy, if we could shave a tremendous amount of costs out of our system just by simplifying the way we think about transactions in healthcare. And there's many other things that we could do in terms of regulatory simplicity. The macro legislation, and this was Andy Slavitt, the acting commissioner of CMS, was saying, this is supposed to be a relatively simple, straightforward piece of rulemaking. It was, and this is physician payments, it was 2,938 pages long. And so it is incredibly complicated. The additional administrative costs that are burdened to the community is really significant when you think about the regulatory impact of MACRA, of Obamacare, of the Affordable Care Act, et cetera.
I think there's a huge opportunity now in electronic medical records. When this was just starting, the argument was we want thousands of flowers to bloom, we want everybody to be innovative, we don't want to close it off, don't want to standardize. I think we're beyond that. And the cost of not having systems talk to each other and not being able to transfer information even within the same system now is it's just prohibitive, and we ought to close our eyes and say, okay, let's do it. Let's standardize some of this.
Yes, back there.
Hi, I'm Sean Glass. I run a healthcare company called Advanti Health. I'm curious your thoughts on price transparency. As you've talked about market-based solutions, and we see a move towards a more consumer-driven marketplace, high deductible plans, consumers making choices, their role in deciding on care and rationing their own care. But there's no price transparency. And the adjudication process for claims completely obfuscates what it may cost for certain aspects of care. So curious your thoughts on why that hasn't gained the traction that people would think it would have by this point.
Maybe I'll start with that. I think the ideas of co-pays, deductibles, and sharing between individuals, perhaps private insurance, and then some kind of catastrophe insurance, I think that is a good model. Because I do think it's important for consumers to, on the one hand, to get back to an earlier question, you can provide incentives for better behavior, what have you, but also not overusing different services. So I think there's a lot of merit to that. I think we do see, whether it's long-term care insurance or health insurance, that it does impact behavior. So I think that should be an important part of whatever solution is made for the ACA or Medicare or any other health program. I think looking at how you create some skin in the game, if you want to call it that, so that consumers are aware of what the costs are and perhaps can be incented to do the right thing.
I think that the price transparency needs to also extend to medical practitioners, because most of the time the cardiologist that is inserting a stent in you does not know what the cost of that is and what the alternatives are. And so price transparency is complicated by the provider community saying, well, my prices are higher because my patients are sicker and I have a different circumstance. And so I think there is complexity in all of this, but I think we're just starting to wake up to organizations saying we actually have to be shedding costs to be more competitive if we're the high-cost organization. And I think we have a ways to go, but I actually think price transparency is a great is a great idea, and we see it in certain markets. We see certain websites that allow us to, do some price shopping and price comparison, but I think we still have a long way to go.
So price transparency is going to happen. It's going to come from the state level to the federal level eventually. I don't think I think it's a foregone conclusion. I think that's where everybody's going towards for all healthcare services. I have no doubt about it. What worries me, though, is that we're not doing a transparency on the value or outcomes portion of it. So you just mentioned websites. There are websites out there, actually. I've Googled, to get a knee replacement. You can look it up in different hospitals in Virginia, Northern Virginia area, in Maryland. And they give you the price of a hip replacement or a knee replacement for that hospital. But it never tells you what the mortality rate is, right? Doesn't tell you how did the patient do so I can't tell whether or not I should pay. And there's a wide range of prices, basically. It's almost like from $5,000 to $50,000. But nobody knows if the $5,000 you're not going to be able to walk out of the hospital, or the $50,000 you're not going to be able to walk out of the hospital. And that's going to be the biggest issue, is that not only we need to look at price transparency or cost transparency or spending transparency, but also outcomes transparency. We need to figure out whether or not Sloan Kettering does a better job of treating lung cancer than the community oncology center down the street from my house, or versus the UCLA Medical Center in California. That data doesn't exist, and it's about time that we start shedding light in that type of data.
But there's a limit to the amount of time that a patient can spend shopping. And for something big like knee replacement, it's probably worth it. Most of the time, you aren't going to be able to do that, and particularly if it's an emergency, you don't have time to do it. So the price that has to be transparent is the premium, and what has to be also transparent, as you say, is the outcomes on the average that plan has in facing different kinds of conditions.
Okay, I think we have time for one more quick question.
Short of full repeal of ACA, if you could advise the president-elect on one thing that you would do to slow the growth or pull back the cost of the ACA and make it more palatable, what would be the top thing on your list?
Can I start on that? Somebody said earlier, I think that it was the congressman who said that Part D and a couple of other things he was talking about came in under budget. So did the ACA. And prices in the individual market are actually lower now than they were, although there have been increases in premiums recently. So the myth, and I think it's now a pervasive myth, that the rising cost of health care is because of the ACA has to be recognized that it's a myth. The rising cost of health care has a lot of origins, and a lot of it are things we've talked about here. It's the incentive to do too many procedures and too many other things, and the rising number of older people, and I'm one of them, that need care, and we do get more costly as we get older.
So my bucket wish list would be to be able to expand on the, whatever you want to call it. I call it IPAs because that's where I grew up in the 1990s, ACOs model of paying physicians. I mean, if we expand on it and truly make it a risk-based initiative rather than just what we're doing, which is touching the toe, we're sticking our toes in the water, and it includes not only physician services, hospital services, but also at some point we need to include pharmaceuticals, because that cannot be left out as a separate entity. Healthcare is a balloon. Pharmaceuticals are part of it. So expanding and moving towards the payment reform through ACOs, IPAs, whatever you want to call it, that's my.
My view is, given the enormous cost of healthcare of all ages, but particularly middle and older Americans, is whatever happens on ACA. I would say maybe I have a criticism of the past administration. I don't think you can do this with one party. I think whatever the solutions that they come up with need to have bipartisan support because these are such costly programs, and the costs are going to continue to rise dramatically. Even if we're successful in bending the cost curve, just the aging society creates a lot of momentum the other way. So I would hope that we can come together with people on both sides of the aisles. I mean, I don't think you're going to get people at the wings of either party, but if we can get enough in the middle where both sides have a stake in its success, I think that's a little bit of the problem with ACA is one side had enormous riding on its success, the other side perhaps not so much, and I think that hurt it, and I think that created some of the myths that we hear. So that would be, I think we can get it done on a bipartisan basis, whatever that reform is, it'd be a big plus.
Just for fun, I'm going to be incredibly inflammatory and say that I think the ACA was a gigantic failure. And the reason why I think it's a gigantic failure is that if you look at the basis of the Affordable Care Act, and let's just fly with me to the Commonwealth of Massachusetts. If we looked at Massachusetts, total health care spend in Massachusetts, if we rank the total health care spend in Massachusetts against any other free market, any other market we can measure in the world, it's the most expensive place in the world to get coverage and to be a citizen in terms of the healthcare impact. I think that there are elements of the ACA that are terrific, but if you look at, for example, in most markets, in Florida right now, some of the exchange-based, some of the people that are still on the exchange, the very few insurers that are on the exchange, the insurance commissioner is saying, actually, you got to boost your rates up higher because I'm worried about insolvency. So we have actually not created this wave of access. And the reason why the risk pools have not worked out is because of the fact that we threw all of these high-risk people into the exchange and they weren't balanced by the healthy people that said, without the mandate, I might not need to get insurance. So I think that as we look at the intent of the law, it had a great intent. The execution of it was incredibly flawed. I think Obama was shocked when all the states didn't say, let's go for Medicaid expansion. I think that they were shocked when they said the states don't want to have their own exchange, that we're going to rely on the federal exchange. I think that in part, the partisanship, the feeling as though this was shoved down people's throat, I think created a little bit of this, the execution flaw that we're seeing that I think manifests.
On that inflammatory note, we're out of time, unfortunately. Unless anybody wants to further discuss possibly euthanasia as a policy option, we can go into that. But thank you all. It was a very interesting discussion.